Good evening. My name is Roxanne Chabot from RBC Consultants. Welcome to another International Dermatology Education Foundation Educational Series webinar. This evening, we are going to be talking about a newly approved foam to help simplify the treatment of seborrheic dermatitis. Our moderator this evening is Dr. Ellie Shabazz, who's a dermatologist at Westlake Dermatology and Cosmetic Surgery in Austin, Texas. For our speaker this evening, we have Dr. Peter Leo, who is Clinical Assistant Professor of Dermatology and Pediatrics, Northwestern University, Feinberg School of Medicine, Adjunct Clinical Professor of Dermatology at the Icahn School of Medicine in Mount Sinai or at Mount Sinai in New York. We'd like to thank our supporter, Arcutis, for making this educational event possible. Before we begin, a couple of logistic tips. If you're having issues hearing the webinar, you can listen to the presentation using your telephone. Just select phone call in the audio pane and the information will be displayed. If you're having technical issues or if you would like to ask a question to our faculty, please submit your questions using the question chat pane at the right-hand side of your screen. At the end of this webinar, a survey will pop up in the browser and will be emailed to you within 1 to 2 days. We'd greatly appreciate it if you could fill it in and send it back to us. And also within 1 to 2 days of the webinar, a certificate of attendance will be emailed to you. Again, if you want to submit questions to our faculty, please use the question chat pane on the right-hand side of your screen, and I wrote a little note there for you so that you know exactly where to type in your questions. So without further ado, I will pass the floor virtually to Dr. Shabazz.
Thank you, Roxanne. Good evening, everyone. My name is Dr. Ali Shabazz. I'm a dermatologist and clinical associate professor at Texas A&M University here in beautiful, sunny Austin, Texas. Next slide. Just a little reminder, thank you for Dr. Kircik for organizing and allowing me to moderate this amazing educational opportunity. The International IDEF, or International Dermatology Education Foundation, is a nonprofit organization whose principal mission is to raise awareness and improve the dermatological care of all over the world through education, especially in underserviced areas. We allow this opportunity is facilitated through virtual webinars that happen on a weekly or monthly basis. We allow world-renowned faculty to teach and educate all of the community dermatologists and dermatology providers around the world about novel therapeutics. Today, we'd like to thank Arcutis for facilitating and sponsoring this event on seborrheic dermatitis and a novel therapeutic, topical therapeutic. It's my pleasure to invite the esteemed guest today, Dr. Peter Leo. He is a clinical assistant professor of dermatology and pediatrics at Northwestern University. He is also an adjunct clinical professor of dermatology at Icahn School of Medicine at Mount Sinai in New York City. And he'll be discussing today a newly approved foam to help simplify the treatment of seborrheic dermatitis. Without further ado, I will hand over the floor to Dr. Leo.
Thank you so much, and I'm so glad to be here tonight, and thank you everybody for joining us. This is a kind of exciting time in dermatology for so many reasons. I think we are just seeing all these new innovations. We're seeing new approvals for diseases that didn't have anything or haven't had any activity in years, and I'm here for it. I am absolutely loving it because we are just finally able to move forward and learn more about these conditions and be able to treat them better than ever before. So we're going to talk about a newly approved foam to help simplify the treatment of seborrheic dermatitis, and that is, of course, Zoryve roflumilast topical foam, 0.3%. The power to simplify seborrheic dermatitis management, one foam once a day anywhere. We can see a nice photo here at baseline in week 8, which is kind of dramatic. We can see the scaling and the erythema significantly different over time. So of course, this is a promotional program sponsored by Arcutis. I'm here on their behalf, but everything we're going to talk about will be consistent with FDA regulations and guidances. The indication for Zoryve foam is really for the treatment of seborrheic dermatitis in adults, but also pediatric patients down to 9 years of age. And that's really nice. I think about this condition as happening usually right around prepubescent patients is where we'll begin to see it. So this is fantastic that we can use it down to 9-year-olds. It is the first in-class treatment for seborrheic dermatitis, which is really exciting. Now, there's a little bit of safety information we want to point out. First, it is actually contraindicated in patients with moderate to severe liver impairment, so the Child-Pugh B or C. It is also flammable. The propellants in there are flammable, so we want to be careful. We don't want to be near open fire or flame or smoking during the use or the application or immediately following. Once it's dry, it should be fine, but especially right when it's coming out, we want to be careful. The most common adverse reactions include nasopharyngitis, nausea, and headache. And we'll get into that a little bit more. So what's also important to know is that this is the second version of this same topical molecule. Its cousin, the other version of it is in the cream formulation, and that is actually indicated for psoriasis, plaque psoriasis, including in intertriginous areas, down to patients 6 years of age and older. So it actually has an even younger age, which is kind of neat. And you can see it's the same concentration, it's just a different formulation, the cream versus the foam. And they, of course, do have these different indications, and we can see again that same contraindication with moderate to severe liver impairment, and then the most common adverse reactions for the cream: diarrhea, headache, insomnia, nausea, application site pain, upper respiratory tract infection, and urinary tract infection. Our objectives are to review seborrheic dermatitis and its impact on patients, to explore the mechanism of action and drug delivery formulation for ZORYVE foam, to review ZORYVE foam efficacy data and clinical safety, and to discuss how ZORYVE can fit into our clinical practice. So let's start with seborrheic dermatitis. I think of it as a really important condition that is often overlooked. It's like the #1 secondary complaint, right? It's not the #1 complaint for most of us, but so many patients, if they're there for whatever it may be, maybe they're there for a lesion of concern, maybe they're there for a primary diagnosis of atopic dermatitis, or maybe they're there for something on their toe. But then the second question comes up: hey, can I ask you about this? Flaking, scaling, erythema, and it really does have an impact on a lot of patients. So we know, as we see these photographs here, it can affect a number of different areas of the body. And I think it really does take an impact on patients. And one of the things I think that adds insult to injury is that it is often sort of brushed off. It's sort of dismissed as not being very important. And I think that's unfortunate, because it really does have an impact on patients. And I think it's one of those things that now, as you're about to hear, we have yet another awesome option to help patients get better, which is so great. So I think we can really promise it and deliver improvement for a lot of patients. Now, what's going on when we think about under the hood, the pathogenesis? It's very unique because it has a very different molecular profile and a distinct skin barrier disruption pattern. So when I think about it clinically, I'm often thinking about my differential. We're thinking about eczema, we're thinking about psoriasis, and then this sort of SIBO psoriasis kind of combination, but it really does seem to be a little bit different. It's in its own zone. And again, like many things in dermatology, I think there is a bit of a spectrum sometimes, or overlap. Patients can have multiple things, but fascinating. So this immunological profile really is distinct, but it does have some overlapping pathways compared to other things. Interestingly, there is a lack of the Th2 dysregulation in adults. So that's kind of fascinating. It seems to be polarizing more like psoriasis in that it's Th17, Th22. And the interesting piece of this whole puzzle is the role of Malassezia yeast. I mean, this has always been part of the story, which is fascinating. Of course, we know this inflammatory process results in the increased cell turnover in the epidermis, which we clinically can appreciate as scaling and flaking. We know that Malassezia is playing a number of roles. Some people think it may be sort of a primary immunologic issue with it, but we also know that it's making metabolites that actually further fuel the inflammation. And we see this story told in some other conditions too. This is a fascinating concept, that some of the dysbiosis, when the microbiome is imbalanced, and this is a good example of that. We think microbiome, we often lock into bacteria, but fungus is an important part of it. And here we're seeing that its breakdown products are actually driving some of this. And then, of course, the skin barrier. It's always a poor innocent bystander in a lot of these conditions, because these inflammatory mediators are messing around with our barrier. So we know there's dysregulation by tight junction and lipid metabolism pathways, and there are some distinct gene skin barrier disruptions that we can see from other dermatologic diseases. So it really is its own thing. It has a lot of things in common. Sometimes it gets thrown into other things, but I think it's important that we view it as something unique and individual. Again, common enough though that you may see it in a lot of other contexts. It can vary in presentation depending on skin tone, location, and severity. And wow, there's a lot of opportunities, because something like 10 million patients in the United States, and this is back in 1977, we don't really have a lot of great recent estimates, but an awful lot of people have this. And we know it typically starts around puberty or just slightly before puberty kicks in. It's probably starting. We just maybe don't appreciate all of the characteristics yet, but presumably some of the oil production, the sebum production in the skin is part of the story here. And it can affect patients throughout their whole life. In fact, a number of patients I see are elderly patients with really severe seborrheic dermatitis. It's often flaky. It tends to be symmetrical. We see these erythematous patches, and the scales tend to be kind of greasy, right? That's sort of the sense we think about them, and they can be sort of white or yellow. Depending on the skin tone, it can look a little bit different. We know that in more richly pigmented skin, it actually can appear more gray or violaceous. And of course, sometimes we will see some dyspigmentation, either hypo or hyper. And that's important to know and be aware of, and to counsel our patients about, because I think sometimes it can be alarming. It's saying, oh, wait a minute, I'm seeing something different than just the redness or just the scaling. I'm actually having a different effect. Is this going to be permanent? What's going to happen here? And of course, the presentation varies based on the location as well. So we often think of the scalp, one of the most common places for it. We know that it can affect the other areas of the body, behind the ears, the face, the chest, the flexural areas as well, and is often associated with itch. That's very important. What is the common binding pathway here? Well, we know it's areas that tend to have a lot of sebaceous glands. So scalp, face, trunk is where we're really thinking about these. And we know that it does affect a lot of sensitive areas, like around the eyes, the eyelid area, the brow is very important, the groin, the axilla, all of these are really important. This is the key, I think, slide for this, because again, some people just, I don't think, appreciate that it has a huge impact on quality of life. But of patients surveyed, 90% said living with seborrheic dermatitis negatively impacts their self-esteem. And in a way, it shouldn't be that surprising. I mean, there's a whole TV industry about dandruff, kind of the mildest form of sebderm, right? Arguably a slightly different disease. I kind of think of it as, again, part of the spectrum, but the dandruff referring to the flakiness, but people are brushing their shoulders, using specialized shampoos. We know it affects people. And then you add to that, presumably, some erythema, the itch as well, and this chronicity of the whole problem. And that I think adds to it. 91% said it has a negative impact on their social life, and more than 3/4 agreed that the symptoms make people think they have poor hygiene. And that's important, because if you're looking flaky and kind of scaly and greasy, it's like, did you wash your face? And I mean, yes, they definitely could, and it's really a primary problem. We know that where it's located also can affect our treatment regimen, right? So if it's in the scalp, we have some options that are helpful, particularly cleansers like shampoos and leave-on preparations. But of course, for non-hair-bearing areas, we might want to go a different route, and that gives us some more options. Heavy creams and ointments are not great for hair-bearing areas, and for a guy like me, it's easy. I don't have much hair for a scalp, but if you have thick hair, then it can be really problematic to get a medicine to that area. So we know we have a bunch of different things we can use currently, some topical antifungal medicines, some systemic antifungals. We use a lot of topical steroids. We use non-steroidal anti-inflammatory agents like our calcineurin inhibitors. And we do have some options, which is great. And I think that for many patients, they can find something that can at least be helpful. But I do think we have a lot of patients who feel kind of stuck or have gotten the same thing over and over. So they're looking for some new potential things that they can do. We know also that our treatment regimens can be complex and time consuming, and that's a big deal for the patients and their families, where if they're trying to put these things on, they are having to do layer after layer and take time and energy while they're in the shower or while they're getting ready at night. So we know patients reported using something like 6 different types of treatments weekly and spending more than half an hour per day on their treatments, which is really kind of striking, but not surprising. And I feel like I'm guilty for doing some of this as well, because I'm often giving patients multiple things that they can use. We also know that we alluded to, patients might not mention it as their first or even sometimes second or third diagnosis or concern that day, but it doesn't mean that it's not affecting their quality of life. We know that even if it's something that's not on the top of their mind, if we ask them about it, or if they do bring it up, they probably are thinking about it, and it's worth bringing it up for patients, especially because there are things that we can do to help them. Enter the hero of the evening, Zoryve foam, a phosphodiesterase 4 inhibitor in a simple to use formulation. And just as dermatologists, I feel like it's one of the most important things that is sort of not discussed enough, that the formulation really matters, that if a patient likes putting something on, that is going to help everybody. We all win. And if a patient hates putting something on, then everybody loses, right? Because a medicine that we give them that they don't want to use or don't use regularly, then we know they're not going to put it on as much, and it might just sit in the cabinet. They might actually never get around to it. So we really know this is important, to pick things that they're going to like and they're going to use. Now, we know that it's designed to inhibit phosphodiesterase 4 with a high binding affinity and activity. And this enzyme is really key because it's playing an important role in the immune homeostasis. It's a regulatory, it affects the regulatory pathway of a number of different inflammatory mediators and cytokines. So we know cyclic AMP, we know the Th1 pathway, things like interferon gamma, TNF alpha. We know the Th2 pathway, IL4, Th17, IL17, and IL23. So the PDE4 is sort of central to a lot of these inflammatory mediators. And that's exciting because it also tells us that it's kind of well suited for something that in some ways maybe sits between a couple of different, again, it's distinctive condition, of course, but it does share some overlap. And I love the fact that this is doing maybe a couple of different central things in this area. And of course, roflumilast is doing it very well. It binds with high affinity and high activity, and that's really important. Now, we mentioned this idea about the formulation. And this is so key because, again, especially something that has to be versatile. It has to be able to be used in hair-bearing and non-hair-bearing areas. We know this is a patient-friendly formulation. It's designed to effectively deliver that active drug without disruption of the skin barrier. It uses a unique technology. It's called HydroArc technology. It's a water-based foam. It has a novel emulsifier that doesn't extract lipids from the skin. And we know what's so cool about this. There's a long story that I won't get into at this point, but the story of finding the proper way to put this in the formulation was using kind of a novel approach, this thing called crotophos. And crotophos was typically used in cosmetic preparations, things like sunscreens, but it was specifically utilized and developed to put into Zoryve. And I think there's just a wonderful story about this. What does that mean for us practically, clinically? Well, to me, it means a couple things. It doesn't strip ceramide fats from the skin. That's really important because we know some emulsifiers can actually do some damage to the skin. It's formulated at a really skin-friendly pH of 5.5, and maybe most importantly for my patients who are a lot of really sensitive skin patients, there's no propylene glycol, polyethylene glycol, there's no alcohols like isopropyl, there's no ethanol in there, no fragrances, no formaldehyde, and it's once daily. It's really cool. So application is as simple as shaking it, dispensing it, and then applying it to those areas, safe again for all the skin and hair types. And again, they kind of use that nice little reminder. One foam, once a day, anywhere, Seb done. I kind of like that. Seborrheic dermatitis is now done, which I really like in a steroid-free preparation. So let's talk about how we know this works, right? So that's a very nice story. That sounds appealing, but tell me, show me the data. What do we have to talk about? Well, we have 2 multi-center randomized double-blind vehicle-controlled studies, and these were once daily application of Zoryve foam, okay, as monotherapy. No concomitant therapies were allowed. These were patients from age 9 to age 87, and we can see they are randomized 2-to-1 to get Zoryve or to get the vehicle foam. The primary endpoint was getting clear or almost clear on the Investigator Global Assessment, the IGA score, but it also had to be 2 points or greater improvement from the baseline, which is really nice. And then we'll have some secondary endpoints we'll look at as well, and we'll also look at safety and tolerability. So we know that the patients who were in the studies had seborrheic dermatitis in a variety of body areas. Scalp, almost everybody, 93%. Face, the majority, 62%. Ears, almost half, 10% trunk, 9% eyelids. Now, why does that not add up to 100? Well, because most of the patients, in fact, 73% had involvement in multiple areas, and that's really important. And that's what I think we see clinically too. Most patients do have multiple areas of involvement. So what did we see? Looking at patients again, we see a dramatic 77% IGA success rate at week 8. So we're actually looking here at the patients who were able to get clear or almost clear, so it was 0 or 1, and had at least 2 points of improvement on that scale. We can see at week 8, more than 3/4 of the patients were able to do that, 77%, which is pretty exciting compared to only about half of the placebo or vehicle group. Now, if we kind of kick it up a notch and say, what about completely clear skin? So IGA score of 0, well, 51% of patients were able to achieve that at week 8 compared to only 28% on the vehicle. The P, you can see, was quite significant at 0.0001. One foam once a day anywhere. What do we see? A 31-year-old patient here. We can see the baseline. We're seeing some scaling, some dyspigmentation at the baseline at week 0, essentially. At week 2, we can see the IGA score has already dropped to 0. She is now clear. Now there's still some residual dyspigmentation, reasonable to give some anticipatory guidance around that. And then by week 8, maintaining that 0, and we can see the pigmentation really does start to look pretty much back to normal, at least as it's projecting here for me. Another patient, 48-year-old male, we can see baseline pretty significant. We're seeing a lot of erythema. This is a moderate on the IGA scale. By week 2, it's down to clear, a 0, and week 8, again, clear. Here's another patient. This is a 9-year-old, a pediatric patient. Also, these are really from the trial. And we can see the scalp, pretty significant scalp involvement here. And we're seeing scalp and then sort of posterior auricular area at baseline, severe. So this is a 4 on the IGA score. By week 2, we've already dropped 2 points. Now we are down to an IGA score of 2. And then at week 8, the primary endpoint of the trial, we are down to an almost clear, a score of 1, which is really neat. We can see another patient here, this patient, we saw her face earlier. We can see the erythema, the scaling of the mid-face area. We see the brows involved, the glabellar area. And by week 2, we went from an IGA score of 3 moderate down to an IGA score of 1 almost clear. By week 8, we've maintained that, maybe even a little better from the week 2 score, but still showing us an IGA score of 1 almost clear. We can see here a 61-year-old male, baseline score of IGA score of 3, and we can see by week 2 it's dropped down to an IGA score of 1. Week 8 maintained an IGA score of 1. We can see that looking at itch relief, it's not just the clinical improvement, the itch relief is also pretty amazing. Week 2, 33% of the patients were able to have clinically meaningful itch relief. By week 4, 48%, and by that primary endpoint, 63% of the patients got the clinically meaningful itch relief, and compared to only about 41% in the vehicle group. We know that there was greater itch improvement from baseline with ZORYVE versus the vehicle, seen as early as 2 days in the STRATUM study, and that's pretty neat. We can see here the percentage change from baseline, so now we're seeing it kind of every percentage change overall, not hitting a threshold, a variable here. We can see how fast things move, and we can see that 48 hours after dosing, the p-value was quite significant difference from the vehicle. And of course, the daily worst score, that itch score, patients reported greater improvement in itch from baseline in 2 days compared to the vehicle. More than twice as many patients, we can see that in terms of percentage. We know also that the patient reported outcomes with the ZORYVE in the STRATUM study. We can look at the daily dermatology life quality index, so the DLQI scores, and we can see a really nice improvement both in patients getting that change in baseline score, and we can see the difference there. And then if we take more of a threshold with 4-point or greater improvement in their DLQI, again, we see a really nice difference in both of those ways of looking at this. So the ZORYVE is really not only signs, but also symptoms, and with, I think, a really important final outcome measure, a quality of life improvement as well. We know it's tolerable and safe for any location and duration. We also understand that in general, one of the things that's nice is the side effect profile is pretty low. So we're going to look here at the adverse reactions reported in 1% or more of patients. This is over the 8-week period. And we can see nasopharyngitis, 1.5%, nausea, 1.3%, headache, 1.1%. And that was it. Diarrhea and insomnia were things I think they were keeping an eye on, and they were reported in fewer than 1% of patients. Now, to me, clinically, this is maybe the most important point. It's not associated with application site pain. It's not associated with atrophy, stria, dyspigmentation, folliculitis, or contact dermatitis. And in STRATUM study, fewer than 1% discontinued ZORYVE foam due to an adverse reaction. So to me, this is really maybe the most important piece, because the question you might say is, okay, well, it's a good story and it works well, but why? Why would I pick this? I mean, this really is it for me. This is what I'm choosing it for. And of course, this tolerability here, we can see this. Very, very nice local tolerability. We can see the ZORYVE compared to the vehicle, very comparable overall. And this is looking at things like the heat, the tingling or stinging sensation, mean tolerability score less than 1 for all time points and treatments groups. 98.9% of ZORYVE foam treated and 100% of vehicle treated patients had no evidence of irritation on the investigator rating of local tolerability. And 92.4% of patients reported no sensation or only a slight warm tingling sensation, not really bothersome. So that's important too, again, especially I feel like for the pediatric patients, and we know this can go down to age 9. So we want to make sure that it's comfortable on the skin. When we look at the changes in hypo and hyperpigmentation, we saw an earlier one, but here's one really specifically showing us here in a 35-year-old male, the baseline, there's quite a bit of dyspigmentation, and we can see by week 8, it really does appear to be much better, which is really nice. Now, of the patients treated with ZORYVE foam who had no hypo or hyperpigmentation at baseline, only 0.4%, 1 out of 271 patients had hypopigmentation, and 5 out of 270, or 1.9%, had hyperpigmentation at week 8. Pretty neat. Now, what about longer term? 8 weeks is great, but we'd like to have a little more data. So ZORYVE foam was actually evaluated in an open label long-term safety study for up to 52 weeks, which is really good. So we get to see a longer term, and we can see that these patients were continued on looking both at safety and efficacy. And this was really designed to mimic clinical practice. And I also love this. Patients could treat to clear, and then they could stop their treatment when they were better and then start up again if they needed. So I love that idea that they can kind of turn it on and off. And we can see we had a 24-week and then an additional 28-week. So we'll be able to look for a long time. And I'm happy to say that, as hoped, ZORYVE foam demonstrated long-term safety, tolerability, and durability of response. So we can see the patients getting that clear or almost clear. It actually kind of slowly creeping up over time, which is really nice. We can see it creeping up, getting up to that 80% at week 52. And the adverse reaction profile was consistent with the vehicle-controlled trial. So those 8-week studies that we showed, the data there is very comparable. So the last piece is, how do we incorporate this into our clinical practice? And I think this is something that makes it very easy for us. We know it's the first-in-class treatment of seborrheic dermatitis in adults and pediatric patients down to age 9. It's a once-a-day foam. It's really elegant. It can be used anywhere on the body. So face, scalp, it could be used on the body itself, the folds, and it can be used as long as needed. There's no limitations on duration of use, and that makes it kind of nice. So the very, very cosmetically elegant, easy to use, and again, been studied in a way that, the way I'll tell my patients is, you can use it as long as you need, but my hope is you're going to be clear, and then you can sort of use it when you need it, when your skin calls for it. If you feel itchy, if you see redness and flaking, then you can do it again for a while. And it's such a nice way that you can do this and not have to worry about multiple steps, multiple treatments, or, really saying we have to be mindful of how much you're using over time. Actual use is quite simple. Give it a good shake before you use it. You dispense it by turning it upside down. You put a little bit in the hand, and then you can just put it to the areas and gently rub it in. It's very lightweight. It kind of disappears. It doesn't feel greasy, and it's pleasant even in hair-bearing areas, which is so nice. And the last piece is that ZORYVE Direct helps eligible commercially insured patients get that access and start it quickly and easily. Most patients have assistance on the copay, which is great, and many patients can actually pay as little as $0. Honestly, it's quite good as long as we do our due diligence. We want to make sure we're using it for the correct indication. So always putting down seborrheic dermatitis. I usually do like to put in the chart what they failed. They've tried topical antifungals, they've tried some topical corticosteroids, or typically my patients are overusing the steroids. So I'm saying, they're using it, it's helping a bit, but they're overusing, and I need something non-steroidal to help us. Or if it's in a special area, they're getting it around the eyes, or it's in the folds, and I'm concerned that they're going to have some issues. Typically, I'm able to get it covered. I usually will use a specialty pharmacy because I find they're a little bit more communicative with me, but even local pharmacies, I've had not too much trouble. So summarizing, simplify seborrheic dermatitis control, dramatic IGA success at week 8. We saw that 77%, but with results as early as week 2, and we saw how fast things were in terms of itch as well. Tolerable and safe for any location and any duration, once daily, non-steroidal. So I always say there's no steroid. This is not a steroid. That's so important, and really designed for all skin types and hair types to be used anywhere. And on that, I will wrap up. Thank you so much for your attention. Please feel free to scan this QR code to provide feedback on your experience at this event.
So I think we have time for some questions. Again, write up your questions in the question chat pane on the right-hand side of your screen. Any additional questions you might be thinking of after this webinar, you can always send to info@idefeducationalseries.com. Again, we'd like to thank our supporter, Arcutis, for making this educational event possible.
Thank you, Roxanne. One of the questions, Dr. Leo, for you is, in your clinical experience, what has been one of the first resolution of signs and symptoms of seborrheic dermatitis? Is it the itch, the redness, the scale in your patients with ZORYVE foam?
I feel like the earliest sign often is the itch. So when I have people with scalp itching, sometimes, especially, we know it can kind of be waxing and waning. So you'll look at that day and you might not see much, but that often is a sign that something's going on. And then I think also just I really enjoy using dermoscopy. So I'll take my dermatoscope and look at the scalp, and you actually can sometimes see kind of the micro flaking happening around the follicles. You can see some of that greasy scale starting, which might not be immediately visible to the eye, especially my older eyes. I find that, it's really nice, especially if you're looking in a dark scalp. The lighting is never good, but when you have a dermatoscope, you really can light it up.
Great. Another question, just kind of more about special sites. Can it be used in the ear?
Yes, I mean, it's not an otic preparation, so I don't think you want to drip it in your ear, but I think it's part of the skin of the external ear is fine. What I usually tell my patients is put a little dot on your pinky, and then you can just gently place it in there. I don't want them to jam it in there. I definitely don't want them to use some kind of a cotton swab or anything to put it deep, but certainly that way would be fine so long as it's external ear.
Patient also, and another question is, would you consider using it 2 to 3 times a week to prevent recurrence?
I think that's a great point and a provocative one. I would just say we don't know. It's not technically approved to be used in that way, and we don't really know. But I do things sort of like that in other conditions, and I don't think it's crazy. I think as we saw in the studies, having them sort of use it as needed seems to work well. It works pretty quickly. But I think, yeah, it could be within the clinical domain to say, could we try to do more of a maintenance protocol? But I'll say in the U.S., we don't really have any medicines like that. In Europe, certain medications are actually approved to be used in sort of a twice weekly or thrice weekly way to maintain, but we really don't have that. So technically all that would be off label, and we just don't really have the data. But I think, again, it sounds like a reasonable thought.
And then the final question is, would you consider it safe in all skin types?
Yes, and I think, we really got to see a range of different skin types studied, and that makes me really happy. I think we're seeing a much more intense focus on trying to represent more broadly. I mean, in the US, we really do. We see people from all over the world, so we have to make sure things are studied appropriately, and I feel very confident skin and hair, really throughout the entire gamut you could imagine, it's quite well tolerated.
Absolutely, I completely echo those sentiments. Great points, Dr. Leo. Thank you, and I think that concludes our session for today. Thank you again, Arcutis and Dr. Leo, for joining us today and presenting on this very important orphan disease. With that, we will also just now conclude the Arcutis segment, and a great segue to next week, or in 2 weeks, I should say, or in 2-3 weeks. It will be on mild to moderate atopic dermatitis in skin of color patients, and the lovely Dr. Jennifer Song from Southern California Dermatology in Santa Ana, California, will present on Tuesday, July 9th at 9:30 p.m. to 10:30 p.m. Eastern Standard Time.
Well, again, thank you, Dr. Leo, for such a great presentation, and also Dr. Shabazz for doing a great job moderating. Thank you all for joining us, and we'll see you on July 9th. Good night, everybody.